Hello everyone. Today in our series of Docplexus KOL interviews, we have with us one of the most renowned and best urologists in India, Dr. Mahesh Desai. He has more than 40 years of experience and he has pioneered modern treatment of various kidney and urological diseases. He is currently the head of robotic surgery at Center for Robotic Surgery. Thank you so much, Dr. Desai, for sharing your valuable time with us today.
Thank you.
So, can you please share your experience regarding the PCNL for the management of kidney stones?
Well, as you know, that kidney stone is very common. It is a global disease. It affects any age, old age as well as young. It can affect any sex. It can affect any economical rich or poor. It doesn't have any boundary. It is global, and it's a recurrent disease. So it's a very common, and for years, if you see the literature, urological literature of last century, you will see the maximum number of article is on stone. And the stone treatment reached its pinnacle since 65 to 70 in open surgery when inotropic nephrolithotripsy was invented, which was a bloodless, complete clearance of the stone, preservation of kidney function. And we thought, that's it. We reached the top in stone management. And suddenly there was a technological explosion and endoscope came in the picture. And though TURP was the first surgery, cystoscope, TURP was a basic thing. But in 1980, there was a few pioneer people who invented lithotripsy, where you can break the stone by a shock wave. And at the same time, Peter Alkin and Card in London, he popularized or he demonstrated first time the percutaneous access to the kidney, and through that you pass a telescope and then see the stone and take it out. So that was a PCNL. And then Paris Castro, he devised the instrument which you can pass from the urethra into bladder into ureter, and you can go and take out the stone in the ureter. So these three inventions came one after another in the 80s. And that changed, and that put the open surgery in the backyard. So question was, which one to choose? And people went for lithotripsy because it was non-invasive, there was no pain, there is no anesthesia or analgesia, and you can break the stone and the stone fragment will pass by itself. But when we studied the result, we found that ESWL was very attractive, but the results were not 100%. They are about 75 to 80%. They may require multiple sitting. So what is the alternative to open surgery? Open surgery could remove almost 100%, but it had a morbidity. So we thought that if you do a percutaneous surgery, maybe the cost of the equipment was less, and then it was a minimal access, and then you can take out the stone. And Joe Sugura was the one who wrote a paper in 1985 about 1,000 consecutive patients he treated with PCNL with 98% success result, except that there was little morbidity to it. So we thought the basic principle of stone surgery is total stone clearance. How you achieve it depends upon the local factor. And we thought, looking at the cost, looking at the way it is done, I thought PCNL was the best option which we can have. And the ureteroscopy, both aware thing. And the cost was less in establishing. So we started with the PCNL. And then over the years, we went on improvising it, improving it. Now we have done about 13,000 PCNL. And then problem was the morbidity. There was a more bleeding to it. There was a more complication to it. and that's because of the larger size. So we thought, why do we need a larger size? Because by the time the laser had already been established, so why can't we reduce the size of the instrument and use a laser to break the stone? So we can reduce the morbidity. At the same time, we can have the benefit of complete clearance. So we, for the first time in the world, we devised a microperc, a 18 gauge needle, 0.9 millimeter telescope, and 200 micron fibers. We could puncture the kidney, which we had learned doing PCNL, and without dilatation, we could break the stone, especially small stone. And then, of course, the people came out with a mini perc, which was a little larger, but not as large as the original one. So today, we find that the miniaturization of instrument becomes the right thing to do. Over the period also, the patient understood that you can have cure for the stone disease. So they started coming and getting done. So now the stone sizes decrease. 80% of the stone are less than 3 centimeter and only 20% are big stones. So here is attempt, the last word is miniaturization for a small stone. But one more thing is remaining. The stone is recurrent. We have to stop recurrence, and for that we have to have an understanding why the stone forms. And for that we have a group society known as the ROC Society, research organization in stone kinetic, which looks at why the stone forms and how you can prevent it. If you do that, you can save lots of man hours in loss of work. You can save the kidney from many things. So that's the PCNL.
Yes. So what are your views on prostate-specific antigen test?
PSA, prostate-specific PSA is a marker. It's not a cancer marker, but PSA tells you a prostate marker. PSA can raise in when you have a BPH, but raise is very little. But when you have a cancer, it rises rapidly, and then you can, that's the indicator that you got to see, and then you got to measure the different part of the prostate, tangential zone, peripheral zone, and then investigate and find out, is it got a cancer? Because now, because of PSA, we've been doing the early diagnosis, and in the early diagnosis, you can cure the patient. You know, the PSA is an indicator. It tells you something is wrong. Either it is a tumor, is a BPH, infection, some manipulation, something is there. So you do a transrectal, you do the examination, and then you do a transrectal sonography and look at the architect of the prostate. And if you feel suspicious, then you can take a biopsy. I think what you feel and that you can see, and I think the biggest discovery after the invention of cystoscope is a biopsy gun, where you can do a precise biopsy of the prostate. And nowadays, with that also, you can do the localized treatment for the prostate cancer.
So what are your views on safety profile of newer drugs for the treatment of prostate cancer?
Well, prostate cancer, you use drugs when the prostate is advanced, either T3, T4, where you cannot operate. And it is, so the anti-androgen which has been used, initially we were using a stilbestrol, which had lots of side effects, especially if you have a heart problem and thing. Now there is the drugs which have come out is a bit safe and you can do it. But one of the bigger problem is the moment you take it for a few years, you get a resistance because the cancer changes the pathway. And so the best option still is removing the prostate at the earlier stage. But if you have missed some time, then the new therapy which has come, which is known as a HIFU, high intensity focus ultrasound or a cryo or a brachytherapy or a radiotherapy. You can destroy the primary and you can treat the secondaries with the medicine. So there are lots of combination you can do it. But drug therapy is definitely nowadays, which is available, are little safer for the heart and the complication.
Can you elaborate on the non-surgical management options for kidney stones?
Yes, non-surgical is like, say, if you have a metabolic stone, uric acid stone, you can treat the uric acid by xyluric and then alkalinize the urine, and you can do it. One thing you remember, the small stone, they pass naturally. Any stone which is less than 3 millimeter can pass spontaneously. 4 millimeter, maybe 86%, 5 millimeter, 66%. We have done this study and no stone above 8 millimeter will pass by itself without damaging the kidney. So you have to make sure that the stone is broken into a small piece. So medical management only for a uric acid or for a prevention. You have a cystine stone or you have obesity, you have diabetes, and all these things you keep it under control, then probably, and plus you have to understand why the stone is formed. And in our country, the causes of stone formations are quite different than the stone in the western region. Here the malnutrition is most important and thinner. And overnutrition on the other side, obesity, can also give a stone. And deficiency of the protein can also give a stone formation. So got to have a balance. I think best thing is not to neglect. If you are living in a stone belt area, have a checkup. Just simple urine examination, look it for RBC or do the sonography just to rule out the stone.
So what is your opinion about an online professional network of doctors like Docplexus?
What is most important is, today I had a email from a patient's son from Bangladesh. And he sent the report and say, what is the option available? I'm not seeing the patient. So sometimes it is a little bit dangerous, but on a broad, you can guide him that these are the options available and these are the result theoretically. So you do consult a specialist and then get this thing done, and then it will be, so that will save lots of time for the patient because internet, everything is available. All the information regarding the prostate available. Sometimes the treatment is also shown on the internet. So it is quite educative.
Okay. So since you have a vast clinical experience, what is your message for budding urologist?
Budding urologists, I think what is most important is attend a conference like this, because in conference you can get the lots of knowledge, and then you can have an interaction with your colleagues. Then you can see what's new equipments are there. And then there are lots of lab where you can do the hands-on training. So it gives you the knowledge, it gives you the stimulus, and then they have to go to the specific place to take the training. And training is most important, because without a proper training, one should not start to practice. Because when you start practice, you should be expert. So I think urology is a very exciting branch, and lots of technology, lots of things you can do. Open surgeries almost disappear except reconstructive surgery or a pediatric surgery. But it is very important that this new technology need to be taught properly.
Definitely. Thank you so much, Dr. Desai, for joining us today. It was a pleasure for us to have you on the platform.
Thank you.
To stay updated on our latest scale videos and interviews, please follow us on Twitter, like us on our Facebook page, and subscribe to our YouTube channel. Happy Docplexing!